The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines Podcast Series, brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and I want to introduce you to our series on the management of immune-related adverse events. ASCO has developed 2 guidelines for the management of immune-related adverse events, one for patients treated with immune checkpoint inhibitor therapy, and a second for patients treated with CAR T-cell therapy. Today, we'll be focusing on an overview of the management of immune-related adverse events in patients treated with immune checkpoint inhibitor therapy, ASCO Guideline Update, and we'll have authors join us for future episodes to discuss the key recommendations for organ-specific management for patients treated with immune checkpoint inhibitor therapy, and an episode to discuss the management of immune-related adverse effects in patients treated with CAR T-cell therapy. Today, I am joined by Dr. Brian Schneider from the University of Michigan Health System in Ann Arbor, Michigan, and Dr. Catherine Bolin from Scripps MD Anderson Cancer Center in San Diego, California, co-chairs on management of immune-related adverse events in patients treated with immune checkpoint inhibitor therapy ASCO Guideline Update, and authors of the management of immune-related adverse events in patients treated with chimeric antigen receptor T-cell therapy ASCO Guideline. Thank you for being here, Dr. Schneider and Dr. Bolin.
Thank you, Brittany.
Thank you for having us.
I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The full conflict of interest information for this guideline panel is available online with the publication of the guidelines in the Journal of Clinical Oncology. Dr. Schneider, do you have any relevant disclosures that are related to this guideline?
I have research funding to my institution from Bristol Myers Squibb and Genentech Roche at the time of panel formation.
Thank you. Then Dr. Bolin, do you have any relevant disclosures that are directly related to this guideline?
No disclosures.
Thank you. Then let's talk about this guideline. So first, Dr. Schneider, what prompted this update to the management of immune-related adverse events in patients treated with immune checkpoint inhibitor therapy guideline, last published in 2018?
Yeah, the previous guideline was widely used and consistently one of the top read articles in the JCO over the last couple of years. And since the original guideline publication in 2018, new data have emerged on the management of immune checkpoint inhibitor toxicities. So our goal was to build on the original guideline with more treatment options, especially for patients who fail initial steroid treatment. New strategies have developed for the management of many toxicities, especially GI, cardiac, and heme toxicities. And ASCO and the panel felt it was important to present these new options to the providers in the community. We also wanted to add sections that the providers would find valuable, including a table with many of the immunosuppressive agents used with typical dosages and schedules. We also added a table of commonly conducted testing while patients are on high-dose steroids, as this is something many medical oncologists may not be used to handling, as we typically do not have patients on steroids at high doses for several weeks or even months.
Understood. Then, in addition to those updates that Dr. Schneider just mentioned, Dr. Bolin, what is the general scope and purpose of this guideline?
Yes, so the Immune-Related Adverse Event Management Guideline Update and the CAR T-cell toxicity guideline serve to provide physicians that are prescribing these therapies with an understanding of the wide range of known potential toxicities of these agents and the best available evidence-based and expert opinion recommendations for their management. So up to 70% of patients treated with immune checkpoints will experience some form of immune-related adverse event, and nearly all patients getting CAR T-cell therapies experience toxicity. So recognition of the occurrence of these toxicities and appropriate management are essential for optimizing patient outcomes.
Definitely, those are key points. So then, Dr. Schneider, what are the overarching recommendations for the management of immune-related adverse events, irrespective of the affected organ?
I think early recognition of the side effect is critical. So the guideline has typical signs and symptoms of each toxicity to help clinicians decide if this is occurring in their patients. Second, I think it's critical to grade the toxicity. We often don't do that with side effects related to traditional chemotherapy outside of clinical trials. So for example, if a patient has a platelet count of 75, I can't think off the top of my head what grade that is. I just know I'm going to hold chemotherapy for a week or two. But grading of the toxicity of these immune checkpoint therapies really is very important to decide whether patients can just be watched, whether they need to start steroids, or whether they need to be admitted. I think still corticosteroids and dose holds are the first steps that clinicians will do. The majority of these toxicities, although it would be nice if we could personalize the treatment based on the particular side effect and what we see under the microscope. If the particular affected organ is biopsied, I think in broad strokes, corticosteroids can be implemented easily, and a lot of our oncologists can be comfortable doing this potentially without subspecialty help. Having said that, I think multidisciplinary care is a must for the higher grade side effects. As we in oncology, we can't pretend to also be cardiologists, gastroenterologists, neurologists, dermatologists, and so on. And although there may be varying degrees of comfort from our subspecialists regarding the management of these toxicities, we do need their help for shared decision making, especially for the steroid refractory toxicities. We always want to emphasize a slow steroid taper, oftentimes over at least 4 to 6 weeks. We get into trouble when we try to get them off the steroid quickly because they do have side effects that the patient may not enjoy. But oftentimes we try to taper them quickly and the side effect comes roaring back. And then finally, to escalate immunosuppression quickly if no improvement with high-dose steroids is observed. Oftentimes that's done even within just a few days, but commonly in practice, there's still hope that the steroid will kick in 2-3 weeks down the road. And that's not a good strategy. If the patient's having significant symptoms and steroids aren't helping, they do need to go on to a more important immunosuppressant.
Those are important notes on the overarching management, particularly on how the adverse effects are different than those in patients treated with chemotherapy and the importance of multidisciplinary care. So then, Dr. Bullen, in your view, how will this guideline impact clinical practice?
So the impact of this guideline update is actually very broad. As with the previous guideline, as Dr. Schneider alluded to earlier, it's been very frequently accessed by readers since it offers symptom outlines and algorithmic recommendations for early identification and the management of immune-related adverse events based on the severity and organ system involved. What's really important to understand is that while initially as hematology oncology physicians prescribing these agents, we're doing so in the setting of early phase clinical trials, we were learning about the toxicities, and those physicians were often managing the toxicities themselves. But now, with the exponential increase in the therapeutic indications for immune checkpoint therapies in cancer, the experience with the toxicities and their management and the questions have also followed suit with an exponential rise. With this guideline update, we have experts among all of the internal medicine subspecialties that are now guiding the hematology oncology physicians in immune-related adverse event management. We enlisted the experts in crafting this guideline update. So in summary, this serves not only as a tool for the prescribing hematology oncology physicians, but also for all of the subspecialists in the community and within academic centers for optimizing patient outcomes in the setting of immune-related adverse events.
Great. Yeah, it sounds like this update will be hugely important for practicing clinicians. So then, in addition to those points raised by Dr. Bullen, Dr. Schneider, what are the implications for patients receiving immune checkpoint inhibitor therapy?
So we really hope this will be an essential tool to help providers quickly treat patients when these toxicities present. Often this is unexpected and busy clinicians may be blindsided by these issues. So these guidelines will provide a quick resource to guide the workup and formulate a treatment plan that will expedite patient recovery. And ultimately, this should help promote quality of life for patients on these therapies and may help reduce trips to the emergency department, hospitalizations, and potentially allow the safe re-challenge of immune checkpoint therapy after resolution of the side effect. Many centers have the advantage of subspecialty support with experience in managing these toxicities, but for providers who may not have immediate access to, say, hepatology or endocrinology, we hope these guidelines will help the oncology providers provide the best treatment to facilitate the optimal clinical outcome.
Absolutely. Those are key for optimal care. Then finally, Dr. Bolin, looking toward the future, what are the important outstanding questions and developing areas of research for the management of immune-related adverse events?
So while our recognition of immune-related adverse events, the testing for them, and management strategies have greatly improved with the expanded use of and experience with these therapies, large gaps in our knowledge remain. Translational and basic science research efforts are underway to understand these gaps, such as with the intrinsic and extrinsic drivers of autoimmunity, such as those with HLA allelic variations and the microbiome's interplay with our immune systems. There are also research efforts underway to develop rapid diagnostic tests to deploy early in the onset of irAEs signs and symptoms, and for the development of biomarkers and modeling tools that will aid us in predicting which patients are likely to experience immune-related adverse events. There have also been some interventional protocols that have attempted to prevent these immune-related adverse events by incorporating immune suppressants along with therapeutic agents, but so far promising results with this strategy remain elusive. In regard to treatment for immune-related adverse events, investigators are working to learn the best strategies for selective immune suppression rather than just the use of glucocorticoids that will control immune-related adverse events while maintaining the clinical benefit of these incredible anti-cancer therapies.
Thank you for highlighting those research gaps, and both of you for your efforts to lead this guideline update. We'll be joined by authors on the guideline over the next episodes to review the key recommendations for organ-specific management in patients treated with immune checkpoint inhibitors, and to review the recommendations for patients receiving CAR T-cell therapy. Stay tuned for these episodes highlighting the sections of the guidelines. And thank you for your time today, Dr. Schneider and Dr. Bolin.
Thank you so much.
Thank you.
And thank you to all of our listeners for tuning in to the ASCO Guidelines Podcast Series. To read the full guideline, go to www.asco.org/supportive-care-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in iTunes or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.